This is the common test that I order for somebody who has the symptoms that I look at that pattern and I go, yeah, it really sounds like thyroid to me. And that's a combination of one or several of the fatigue, the I don't sleep well, you know what, I'm having more trouble maintaining my weight than I used to. My hair is starting to fall out. My eyebrows are gone on the outside corners. I'm constipated. My hands and feet are cold all the time. So that's a very basic list. There's probably 24 symptoms that I look at before I say, yeah, okay, we need to check this. What we've got here is the first one, the free T4 and the free T3. Thyroid hormone in your body circulates through your blood bound to a protein carrier. It has to do that. Otherwise, your kidneys would just suck it all up and you would pee it all out and it would be gone. You want to maintain a reservoir of this stuff because it's essential to life. You pretty much can't live without it. When we say free, what free means is the tiny percentage that is not bound up to the proteins. And it is more telling for what I want to know about a patient because the protein levels in your body go up and down. They go up and down with your period, with stress, depending on how sugary a food you ate yesterday or this week or this month. There's lots of things that makes those protein levels go up and down. So the total T3 and the total T4, not as useful for following what's your thyroid availability right now. So free T3 and free T4 I use. Now, your endocrinologists are going to tell you, oh, free T3 is a really inaccurate test. It's notoriously inaccurate. Well, the problem with T3 is that it's very short acting in your body. And it'll be higher in the morning and lower at night. And it goes on kind of a circadian cycle along with your cortisol. It goes up and down through the day. So it depends on what time of day you tested it. If you're taking a thyroid medicine, it also depends on what time of day you took your thyroid medicine. Depends on what you ate between then and the time you got the lab. It's very persnickety. And this is one of the reasons that I think that a lot of doctors are just not gonna deal with this. It's too persnickety. It's too time intense. It's too education intense for a lot of people to deal with. The next one is total T3. And I just told you how inaccurate this is, because it goes up and down with those proteins. The reason I need that total T3 is because I'm going to compare it to reverse T3. So I'd explain what reverse T3 is. In your body, from your thyroid gland, there are 3 different hormones that are being made, and it's T4, which is 89% of what comes out of your thyroid gland, and then T3, which is about 10% of what comes out of your thyroid gland, and then reverse T3, which is about 1% of what comes out of your thyroid gland. The reason it's not 100% T4 is because the enzyme that puts the iodine molecules on the chain of thyroid molecules that are being made is not 100%. It's like the T3s and the reverse T3s are factory rejects, kind of. They're coming out with the other, but that ratio is pretty constant.
Just to make sure I'm getting that, there are some unintended modifications to the enzyme that's supposed to be only creating free T4, and therefore you get some free T3 and reverse T3 that exit from your thyroid gland.
Yeah. And it may not be intentional, and I say that the T3 is a reject because it's kind of not. When your TSH is high, the percentage of T3 that comes out of your thyroid gland will actually go quite a bit up. It might go as high as 20% rather than 10%. When your T4 goes high and your TSH goes down, that percentage might go as low as 7%, like a 1-to-15 ratio. So T3 is not static coming out of your thyroid gland. That's something that most people just totally ignore. So it comes out of your thyroid gland in healthy people at this 10-to-1 ratio with T4. And then the reverse T3 is also 10-to-1 with the T3. You can use that ratio to say, okay, in your peripheral blood, you have a 10-to-1 ratio. That means you are smack on with your balanced production of T3 versus breakdown of T3 versus high reverse T3 versus low T3. I use that ratio. But reverse T3 is a total measure. They don't have a free reverse T3. It's only total reverse T3. And a lot of doctors do not know that, and they don't publish it in the lab. If you look at the literature in the lab as you're ordering the test, it says it's LCMS, but it doesn't say this is a free hormone level or a total hormone level.
Got it.
So people who are not doctors, who are not educated in this, they try to use a free T3 to reverse T3 ratio, and it's meaningless. I say raisins to watermelons when it's free T3 to reverse T3. There's no comparison. But total and reverse T3, you can get that ratio, and you say in simple division, it's the total divided by the reverse, which is on this slide right here. If you ask the lab for this, they're not going to give you a reference range. If you measure this and there's 2 studies that he found measuring this in completely asymptomatic healthy people, and it was 11.5 in one of the studies and 12.5 in the other study. It comes out of the thyroid at that 10-to-1 ratio. We can say anybody who's less than 10-to-1 is breaking down their T3, not building their T3 peripherally in the tissues.
Do you then assume that it's always that consistent ratio when it's leaving the thyroid hormone? Therefore, when you measure it, if it's too low, it must mean that there's a destruction of the total T3.
Exactly. So to go back into the physiology for just a second, the T3 that comes out of your thyroid gland is only about 20% of what your body needs on a day-to-day basis. So the rest of the T3 that you have is coming from intracellular conversion through enzymes.
From
And
T4
I mentioned,
gets converted into T3,
correct.
Right?
That's the only other way you get T3 is by getting converted from T4. The problem is that's also the way you get reverse T3. If the wrong enzyme acts on your T4, it takes the wrong iodine molecule or the wrong iodine atom off of the T4, and it's reverse T3 instead. Now, reverse T3 is not an active molecule, but what it is a signal, because it's a different enzyme that's doing the job. It's a signal that the activity of the non-making T3 enzyme is too high, because that enzyme also breaks down T3.
Okay, that means if the ratio of the total T3 to reverse T3 is low, it could it be because, well, either way, it's an enzyme problem, whether you don't
Yes.
have enough conversion of T4 to T3, or if you have too much production of T3. What you're really getting at here is you don't have enough T3 in your system.
I don't know if I mentioned T3 is very short acting in your body. Reverse T3 is also very, very short acting in your body. But that ratio from hour to hour stays pretty constant in a single person. You can look at it and go, okay, it was 7 last month and now it's 12. What did we change? Okay, we've done something. And the patient's symptoms will track that ratio. It's something that I use clinically. I mean, your body has several ways to break down excess T. If you're taking a lot of T4, say for example, you have Graves' disease and you've just got a ton of T4 circulating, your body is going to want to try to get rid of that and break it down. It's dangerous. It's life-threatening, right? So one of the ways that it does is it makes very, very high levels of this deiodinase type 3 enzyme, which is the one that will break down T4, but it also breaks down T3. Because what it does is pluck an iodine atom off in a particular location off that molecule.
And is that the one that creates reverse T3?
And it creates reverse T3 from T4, and it also breaks T3 down into T2.
Got it. I see. So effectively,
it's an iodine extractor.
Right. That makes sense. In the case Graves' disease, meaning autoimmune disease that's causing your thyroid to release too much hormone.
Correct.
T4.
Yeah.
And your body, if it wants to get rid of the T4, it tries to convert it into T3, which is reverse T4,
yes.
which is biologically inactive, rather than converting it to T3, which would just cause you to have more of the symptoms of too much thyroid hormone.
Correct.
Got it. That's super interesting. When you check somebody's free T3, 2 questions on this. What time of day do you prefer to check it, given that there is so much variation? Let's just assume it's somebody who's not taking any thyroid hormone.
Any thyroid medicine. Because of the other labs that I order on a person who's coming in for a fatigue workup, I almost always try to get right at 9 or slightly before 9 a.m. for those people. The main reason for that is that I'm also checking metabolic labs. I want to know what their insulin level is. I want to know what their cortisol level is. And those tests really must be done in the morning. T3 is also highest in the morning. And so it seems like a good time. I try to make it consistent, and the labs are open by 9 almost always. Can you get in between 8:30 and 9? I could say, oh, well, you should get it done at 7 right when you wake up. And like none of the labs are open. So that doesn't actually work.
Got it. And if the T3 to the free T3 level is normal, is it still helpful to look at the ratio of total T3 to reverse T3?
Yes, it absolutely is. Type 2 hypothyroidism. And what it is that you will look at somebody's labs. You'll get this set of labs, and free T4 will be normal. Free T3 will be normal. It might even be in the upper half of the normal range, which is where I want it. Their total T3 will be fine. Their TSH will be fine. Maybe even in the lower half of the range, which is considered good, like 1 to 1.5 to 2. And their reverse T3 will be 30. And I'll be like, okay, I know what's wrong with you. And I see this over and over again. And it's in people who come in and aren't on any thyroid medicine, but I especially see it in patients who come in on levothyroxine.
And they're having symptoms.
And they are terribly symptomatic.